AI ethics in healthcare is not some abstract classroom debate. When an AI system gets it wrong, patients can get hurt. Think about a dermatology AI trained mostly on light skin tones that misses melanoma on a patient with darker skin. Or a predictive model that uses insurance claims as a stand-in for health needs, which quietly underestimates care for patients from disadvantaged communities. Or an ambient scribe that mishears a patient and writes something inaccurate into the medical record. None of these are edge cases anymore. Healthcare already has strong ethical traditions: the Hippocratic Oath, the Belmont Report, and the four principles of biomedical ethics: autonomy, beneficence, non-maleficence, and justice. AI doesn't replace these principles, it just creates new ways to violate them and new questions about how to protect them. AI systems learn from data, and data reflects the world we actually live in, inequities included. Bias can creep in at several points. Training data bias happens when a model learns mostly from one demographic group and performs worse for everyone else. A 2019 study in the journal Science found a widely used healthcare algorithm was biased against Black patients because it used healthcare spending as a proxy for healthcare need. Since Black patients historically had less access to care, the algorithm underestimated how sick they actually were. Label bias happens when the training answers themselves reflect biased clinical practice. Selection bias shows up when training data comes mostly from academic medical centers, so the model struggles in community or rural settings. And measurement bias comes from the devices themselves, like pulse oximeters that are less accurate on darker skin. These biases aren't hypothetical. Dermatology AI performs noticeably worse on darker skin tones. Cardiac risk models trained mostly on male patients underestimate risk in women. Mental health screening tools calibrated for one cultural context give inaccurate results in another. And resource allocation algorithms can end up perpetuating the same disparities in access to care that already exist. So, what can you actually do about this as a healthcare professional? Ask about the training data demographics before your organization adopts an AI tool. Monitor how it performs across different patient subgroups after it's deployed. Report any disparities you notice to both your institution and the vendor. And above all, maintain your clinical vigilance. Never let AI override your own judgment, especially when you're treating patients from underrepresented groups. Should patients know when AI is involved in their care? The trend is clearly moving toward yes. With ambient scribes, patients should be told an AI system is recording and processing their conversation, and most health systems using these tools require verbal consent. With diagnostic AI, if a tool flags something on your imaging study, many ethicists argue the patient has a right to know, though exactly how that gets disclosed still varies. And if a clinical decision support system influenced a treatment recommendation, patients have a reasonable interest in knowing that too. Right now, there's no universal legal requirement for AI disclosure in healthcare, unlike the EU AI Act's transparency rules for high-risk systems. But the ethical case for transparency is strong, and regulation is likely coming. Many AI models, especially deep learning systems, work as black boxes. They can spot a finding on a scan or predict a patient's risk, but they can't explain their reasoning the way a person can. That's a real tension in healthcare, where clinical reasoning is supposed to be transparent and defensible. When a physician makes a diagnosis, they can walk you through their thinking. When an AI flags something, that reasoning often isn't accessible at all. Researchers are working on this. Explainable AI, or XAI, aims to build models that can show their reasoning. Attention maps in imaging AI highlight which parts of an image drove the output. Confidence scores show how certain the AI is. And citation linking, like the approach used in Abridge, connects AI outputs back to the source data they came from. When AI contributes to a decision that ends up harming a patient, who's responsible? The physician who acted on the recommendation, the hospital that deployed the tool, the vendor who built it, the data scientists who trained the model. Right now, current legal frameworks generally hold the physician accountable for clinical decisions, no matter what tools inform them. That's a critical point to internalize. Using an AI recommendation doesn't lower your professional responsibility. If you follow an AI suggestion without applying your own clinical judgment and the patient is harmed, the liability lands on you. That's not a reason to avoid AI tools. It's a reason to use them thoughtfully, always weighing their output against your clinical training and what you know about the individual patient in front of you. A few organizations have already published guidance here. The WHO's Ethics and Governance of AI for Health lists 6 principles: protecting human autonomy, promoting well-being, ensuring transparency, fostering responsibility, ensuring inclusiveness, and promoting responsive, sustainable AI. The AMA's policy on augmented intelligence stresses that AI should enhance physician judgment, not replace it, with real requirements for transparency, fairness, and oversight. And the Coalition for Health AI, or CHART, is building standards for trustworthy healthcare AI across the industry. Bias can harm real patients, transparency with patients matters, and you stay accountable no matter what the AI recommends. Head to this lesson on FreeAcademy.ai and work through it yourself, or bring these frameworks to an AI assistant like ChatGPT or Claude and talk through how they apply to your own practice.